He's done a lot of things, Commonwealth Fellowship, Masters in Business Administration, and he's been to the US, the neurocritical care at the Royal Victoria Hospital, and also then finally he landed up in neuro anesthesia. I'm glad for that, because after doing his PDF in CMC Vellore. So you can see a true academician is going to speak now, and he's going to talk about anesthesia concerns in intracranial SOL, that is posterior fossa tumors. Just a small word for the residents who are listening. Many of you feel that neuroanesthesia, we needn't know much because we're not asked in the exam, but that is not the main thing. The main thing is that you please listen carefully. These are the small periods where you can imbibe as much as you can. And that is because you have to step out of after your PG into the big world, into corporate hospitals or other big centers, where you will be practicing everything. You may be sent to neuro OTs or cardiac OTs or neurocritical care, which is part of the main critical care. So these are those lectures which are very valuable for you. Just 2 or 3 of them, just to get a grip on what is happening in neuro world right now. So over to you, Dr. Prashant Kumar.
Namaskar, friends. Welcome to this new session and new topic. I'm Dr. Prashant Kumar, and in next few minutes, we'll be discussing about anesthesia for posterior fossa tumors and per se all the surgeries which are pertaining to posterior fossa. Posterior fossa is unique, and it is challenging for anesthesiologists as well as surgeons both. So it's not that we are only worried, the surgeons are equally worried. And posterior fossa posted for surgery are generally patients for tumors, or they are congenitally acquired craniovertebral junction anomalies that may be Arnold-Chiari, or it can be some emergency procedures where they come for the release of pressure from the brainstem. Why are we discussing it here? Because it has certain challenges, and these challenges are because of vital structures, brainstem, cranial nerves, and cerebellum. So all cranial nerves except 1 and 2, that means 3 to 12 cranial nerves pass through this. It is a very small confined space, so any small increase in the volume leads to larger symptoms and pressures. Most of these surgeries require awkward positions because of anatomy of lesion, which is complicating the surgery. Longer duration makes it a challenge, and these patients have potential to develop hydrocephalus early. Cushing's were probably the first one to report a large series on posterior fossa tumors, and he has a lot of contribution towards neurosurgery, neuroanesthesia part. The posterior fossa or infratentorial fossa is very compact, rigid compartment. So small addition of volume, it might be because of tumor or hematoma within that space, can result in significant elevation of compartmental pressure. Surgery presents challenge, and some patients may be requiring emergency surgeries, like patients who developed acute brainstem involvement. If you look at the anatomy, the base of the skull, so it can be divided into anterior, middle, and posterior cranial fossa, which has the largest opening in the center, that is foramen magnum. So if we look at the skull base and look at the structures, so structures apart from the midbrain, pons, medulla oblongata, the third, fourth, fifth, sixth, all these cranial nerves, they pass through the posterior cranial fossa. So that is why these patients become symptomatic very early. It is the deepest fossa among the 3 cranial fossas, and it has foramen magnum in central located one. Vital structures, cerebellum, pons, and medulla oblongata, all 3 sitting in the posterior cranial. This surgery can be for tumors. It can be for the vascular lesions, which may be AV malformations or aneurysm, or as we said, craniocervical abnormalities, or there can be certain patients which come for evacuation of hematoma or decompressive cranial surgeries, like this patient developing massive hydrocephalus would require a shunt first before going out for the surgery. If we start discussing tumors, then we need to remember certain points that these tumors are more common in children than adults. It's only 50 to 20% of brain tumors in adults which are in posterior fossa, while nearly 2/3 of childhood tumors are in posterior fossa. And astrocytoma, medulloblastoma, these tumors are very common. Tumors, based on their anatomy, can be in anterior compartment or posterior compartment based on the fourth ventricle. And these tumors can be intraaxial or extraaxial, that means within the pia or without the pia. So gliomas are intraaxials, and CP angle or meningioma, epidermoids, schwannomas, these tumors are extraaxial tumors. Then there can be intraaxial, exaxial, and posterior compartment as well, and intraaxial tumors will be cerebellar astrocytoma, medulloblastoma, or angioblastoma. Histologically, these tumors can be from primitive neuroectodermal tumors, which are tumors occurring in the brain, or they can be sympathetic nervous system tumor. There can be medulloblastoma, pineoblastoma, ependymoma, or there can be glial tumors, that is, these are astrocytoma, ependymoma. Hemangioblastoma, cystic cerebellar astrocytoma are common tumors here. The clinical presentation of these tumors or the pathology will depend on site of tumor, biological behavior and aggressiveness of tumor, and the rate of growth. And symptoms may be maybe focal compression of cerebellum or brainstem center, or there can be increased intracranial pressure. Focal compressions like cranial nerve dysfunction, third nerve, fourth nerve, sixth nerve, resulting in ocular palsy, diplopia, or cerebellum like nystagmus, or truncal ataxia, common finding with midline tumors, which is manifested by tendency to fall frequently and widely paced gait. So this is the classical finding for any posterior fossa anomalies. Long tract signs indicate involvement of brainstem. These patients may present with headache, which is the most common in patients with posterior fossa tumors. There can be stiffness, neck pain, head tilt, suggesting tonsillar herniation. Patient may present with vomiting, strabismus, blurring of vision, meningism, dizziness, microcephaly in children because they can have expansion of head. So patients can have skewed deviation of eyes and nystagmus. There can be irregular respiration, and the patient may present with sudden death as well. Surgeries may be done to decompress the posterior fossa, or curative resection, or to take a histopathology for the diagnosis. When indicated, to treat hydrocephalus by shunting also, or there can be sometimes lumbar puncture as a contraindication for it. Now, few things which we need to remember whenever we discuss from the exam point of view in terms of posterior fossa. This becomes more interesting, one, because what we discussed that these are challenging. The other is interesting question which comes up is the positioning. Because these patients require awkward positioning, the surgery can be performed in any of these positions. It can be supine, it can be lateral, it can be prone, it can be lateral 3/4 or the park bench or the sitting. Now, if we discuss them separately, sitting position requires maximal rotation to the contralateral side, and further can be by putting some roll under this shoulder area. So this head goes to one side, which is extreme rotation. What we need to also remember is that head up position or reverse Trendelenburg, which we will discuss later also, causes decrease in cerebral perfusion pressure, for every 2.5 centimeter vertical height increase of the head. There are chances of reduced venous return, which may cause raised ICP, which may lead to macroglossia or brachial plexus injury in the post-op. Lateral position, we all have seen in various other surgeries as well. So, but what is there? There is increased chances of bleeding from the sinuses, but less incidence of air embolism, which we are worried about. We should always protect the inferior shoulder by putting a shoulder roll here. There can be lateral popliteal nerve injury. There can be ipsilateral superior shoulder, broad shoulder patients may come in the surgeon's side. So this needs to be pulled down. So like this bandage, this is getting pulled down. And this is a good approach for CP angle lateral tumor. Prone position looks simple in terms of it gives a very good open view, good access, more commonly used in children, and head is usually elevated to assist in gravity-related venous drainage. Park bench position is a different position. It's different from the lateral, only in terms of you need to imagine how a person or you would be sleeping on a bench in the park. So what happens that when you are on the bench in a park in a good mood, your shoulder drops down. So similarly, here the patient's shoulder drops down and head is obviously in the ring. So it can be used for lateral midline lesions, that is fine. And if the patient table is further tilted, it gives a very good view. The precautions here are that this lower limb, which has to be supported and given good padding. Sitting position, which is the most challenging one out of all these and most interesting one also when you start working in theaters with these positions. With surgeons, they are very fond of it in terms of gravity assisted blood and CSF drainage away from the operative site. So everything which falls down, so they get a very good clear field. And cerebellar hemisphere also fall down with the gravity so that the surgical field is very clear. Improved access for endotracheal tube and thorax for monitoring for us also. So this part you can see even after draping here. But there are certain things which we are worried about, like physiological changes, which in CVS is decrease arterial pressure, reflex tachycardia can be, and there can be increased SVR. Respiratory system, there can be increased FRC, and there can be easier diaphragmatic exertions. There is decreased cerebral blood flow and cerebral perfusion pressure. And in patients who cannot tolerate an abrupt increase in SVR, sitting position may represent a physiologic threat. So we need to be careful about it. And we need to avoid this position in known intracardiac shunts, like patients with ASD, VSD, known pulmonary artery PA shunts of the patient, severe hypovolemic patients, orthostatic hypotension patients, patients with cervical spine disease, and elderly for all these reasons with uncontrolled hypertension also. Patient remains semi-recumbent, back is increased to 60 degrees, so the patient lies on table, and then once induced, you start raising this part up as well as the leg part up. Put a pillow support under the legs, and this table goes up, and then the frame is fixed to the table, and this makes the surgical field totally open and with the gravity. We need to have some measures to avoid hypotension. So the pre-positioning hydration can be one method. Then wrapping of the legs with elastic bandage is the very common thing I do regularly. And even the stockinets, the good stockinets given to the patients help a lot. And still we may require some pressure support for the patients. So what we are worried in this position is hemodynamics, venous air embolism, paradoxical air embolism, especially in patients with VSD, brainstem nerve stimulation if the patient is being monitored, macroglacia, quadriplegia, pneumosyphilis as the complication of these positions we need to remember. All these patients need to be preoperatively evaluated, looking for features of raised ICP, ataxia, headache, nausea, vomiting, cerebellar sign, motor sensory involvement, and the diagnosis requires imaging, which will find a lesion in the brain. Cardiorespiratory reserve, integrity of autonomic system should be assessed for all these patients because they might have some shift. Neurological deficit with the cranial nerve should be documented. Contraindication to sitting position should be looked for. Patent foramen ovale should be assessed. Neck mobility and symptoms associated with flexion or rotation. Persistent vomiting patient will have electrolyte abnormality. So please, while assessing these patients, please document all these. Pre-medication is always based on patient's physical status, ICP, and patient's anxiety. Per se, sedative pre-medications are not recommended for these patients, but if your patient has good GCS, no gross anomaly, patient will require some sedation. What you need to assess is level of anxiety and the hemodynamics, what your patients have. The only worry for sedation with people is about respiratory depression and CO2 retention, which may cause further deterioration. But in general, patients nowadays being assessed are not a contraindication for mild anxiolysis or some sedation. Antihypertensive medications, anti-edema measures should be continued, and we need to give remedy. Standard routine monitoring is required. Monitoring for venous air embolism, if we are suspecting, that can be a precordial Doppler, and others also, we will come to that. Then some patients would also be under neurophysiological monitoring of SSSB or VAER. Intravenous induction is done for all these patients with me. Confirm position, endotracheal tube, and what is preferred is reinforced endotracheal tube. We need to preserve autonomic activity, IPPV with paralysis, off lighter levels of anesthesia, which preserves the sympathetic activity. Always remember for adequately hydration and relaxation. If the patient is for motor evoked potentials, then the paralysis is to be watched for. Concern is about adequate cerebral perfusion pressure, which is decreased when head is elevated, and for every 2.5 centimeter, it decreases by 2. So you need to remember that. And surgical response to cardiovascular response. For recovery, prevent abrupt rise in blood pressure. You do not want the blood pressure to shoot and any extra bleed in the post-op, which may cause further damage to the patients. Rapid awakening to assess neurological status. And here comes the role of desflurane. If you want to use, there is no specific contraindication, but per se, ISO remains better for all neurological ones. In cases where there is extensive brainstem manipulation or some cranial nerve damages are expected, delayed extubation in terms of elective ventilation can be considered. Another question which can come for you in this topic is venous air embolism. Old thing with very high incidence, less detected, occurs in surgeries where head is higher than the heart. Most common becomes in sitting position, and we discuss that position in this chapter only. Mortality, morbidity directly linked to not on the amount exactly, but the rate of air entry, which is more important. So there is facilitation of air entry by subatmospheric pressure with an open vein in the surgical field, because there are non-collapsible venous channels, which are diploic veins or dural sinuses. Children experience greater hemodynamic derangements. So severity depends on surgical site, degree of head elevation, and negative pressure between right atrium and surgical site. So here comes the role of hydration. So if your patient is hypervolemic, all these changes would be profound. Slow continuous entrainment causes mechanical obstruction and local hypoxia, and there would be reflex vasoconstriction. Microvascular bubbles go to the endothelial mediator, resulting in complement production and then cytokine release with free active molecule, which may cause bronchoconstriction. Rapidly entering air bolus results in airlock within the right side of the heart, and this is as simple as that if you have a minor air bubble in your IV set which is going in, it blocks it. So imagine the same thing happening, one air bubble going to the heart, right side of the heart, it will block it. So that causes the right heart block. 5 ml per kg increases the capacity, so that will cause a block. Diagnosis is like what you routinely would be doing in theater, is decrease in end-tidal carbon dioxide. And after that, later comes decrease in BP, which you can determine with a stethoscope also now. The most sensitive method to determine is transesophageal echo, followed by transthoracic echo. Complications are in CVS, it will cause dysrhythmias, hypotension, changes in heart sounds. Pulmonary would be hypercarbia, hypoxemia, pulmonary hypertension, pulmonary edema. CNS would be hyperemia, brain edema. Detection would be, if you are able to put a esophageal stethoscope, the most cost-effective equipment you have, you will find Millwee-Warmer. So this another word is there for your exam. Precordial Doppler, most sensitive, and small volumes of air can be detected. Pulmonary artery catheter, if in place, it can detect pulmonary hypertension from the mechanical obstruction which is causing. Capnography has very specific role, but it detects the gradient and there would be a delay. And if you have a Doppler, that would be much faster. And there is end-tidal nitrogen monitoring, which is also very specific for air, because nitrogen would be reaching only if air goes in blood. Transesophageal detects even 0.25 ml of air when it is in the right side of the heart. So that is the sensitivity we have. Used for the screening of patients, then there can be transcranial monitoring of middle cerebral artery. But no maneuver is 100% effective when it comes to prevention. Adequate hydration, avoiding hypovolemia, wrapping of the lower extremities, as I said, good surgical exposure with careful dissection, liberal use of bone wax to close all these veins which can be there, avoiding the nitrous oxide, minimizing head elevation. But what to do if it happens? Immediately notify the surgeon to stop the surgery, pack the field, and put a lot of fluid there. Jugular compression can be considered, but it has its own effects. Lower the head, make a lateral position with right side up, it is Durant position, so that the air doesn't flow further. Aspirate if you have a catheter right in place. Discontinue nitrous oxide if you still used. Make 100% oxygen. Pressure or inotrope to support the cardiovascular. Jugular venous compression, few words. If you say it in Viva, you might be asked, what is jugular venous compression? So it raises dural sinus pressures in both supine and sitting positions, but it can cause cerebral venous outflow obstruction, carotid artery compression, carotid sinus compression, bradycardia. Everything can happen when you compress the jugulars. It should be given very carefully. So if you have a right atrial catheter, aspiration of right atrial catheter initiated as early as possible, effecting in reducing the morbidity, useful in confirming diagnosis of VAE also. Multi-orifice catheter is more effective. Catheter tip should be 2 centimeter below superior vena cava atrial junction. So for all these patients, what we prefer is putting up an internal jugular catheter and then checking the tip position with the C-arm available in theater. So it should be confirmed with radiograph, pull back to them. Then there is also role of intravascular ECG, which we haven't practiced any time, so I have no experience with it. But it's a CVP catheter with electrolyte solution, and this electrode placed in the middle of right atrium, and it initially shows increased positivity. So there used to be catheters with the wire which used to get connected with the ECG electrode. And with the position of this tip at different places, you get the intraatrial ECG differently. Post-op care for all these patients, goals are to provide supplemental oxygen, perform serial ECG, chest X-ray examination for any developing anomaly, serial blood gases, and if arterial emboli is suspected, provide hyperbaric compression if available. Another question which can come to you is paradoxical air embolism, which is passage of air across the interatrial septum through a patent foramen ovale, which is present in 25% of all adults. Incidence is around 5 to 10%, and predisposing factors, significant increase in pressure in the right side of the heart and hypovolemia. So if you correct the hypovolemia beforehand, you can avoid this happening. And it occurs when RA pressure is more than LA pressure, and the pressure gradient required to open patent foramen ovale is only 5 mm of Hg. So only this much of the gradient developed may cause paradoxical air embolism. Use of PEEP increases incidence, and consequence are systemic emboli. Another complication of all these patients is pneumosyphilis, which is most commonly seen as the delayed awakening from anesthesia or non-awakening. And if you take the patient which is not awakened for the last 15 minutes to the CT scanner, you immediately find a pneumosyphilis sitting there in the supratentorial space in upright position. If we have used nitrous oxide, chances would be increased. Diagnosis is bro-upflateral radiograph or CT scan, what is commonly done. A twist drill hole to remove puncture the dura is done. Then brainstem stimulation, which is irritation of lower portion of pons, upper portion of medulla. So it can cause manipulation of 9 to 12 cranial nerves, bradycardia, hypotension, tachycardia, hypertension, ventricular dysrhythmias, loss of control of patency of upper air. So what happens that if there is direct stimulation with cautery or surgical field, this can be troublesome intraoperatively. Then another dreaded complication is quadriplegia, which is due to neck flexion resulting in stretching or compression of the cord. So if it is too much stress, the patient can develop quadriplegia post-op. Patient with degenerative diseases of spine may need preoperative radiological studies, may warrant SSCP monitoring during positioning. Another complication of these positioning in this particular surgery is macroglosia. So there is swelling of the upper airway due to edema. And this is also because of the neck flexion, which causes macroglosia due to edema occurring at the time of reperfusion. So always simple rule is to maintain 2-finger breadth between chin and sternum. So whatever position you make, if you are able to put your 2 fingers at this place between the patient, so neck and the sternum, be it in sitting, be it in lateral, be it in park bench, be it in prone, you will be able to save this. So points to remember are posterior fossa surgery poses unique challenge to anesthesiologists as well as surgeons. Patients are symptomatic with this, even with small lesions because it's a small tight compartment. Positioning poses special challenges. Venous air embolism has high chances during these surgeries. Great vigil is required for perioperative care. Best wishes for your examination. Thank you all. Bless you.
Hello. My video is not working, but I think you can hear me out. Thank you so much, Dr. Prashant. And that was a very nicely done lecture. It was simple, it was easier to understand, and also you have touched the most important points. Most of the important points have been covered. And I think, put in a very simple language, which is, I'm sure all the PGs have understood, and they'll be able to come out with the answers at the right time when they're asked in the exam. So regarding questions, I'm not sure if you should take them. We can take them now if there are, and I can't see anything in the chat or in the question answer this thing, but anybody, just a minute. But I mean, should we proceed if there are no questions on this? Or what I'd like to say is to most of the people that posterior fossa, like Dr. Prashant very nicely said, that it worries everyone, the surgeons as well as the anesthetists. So it is one of those most challenging areas that we face. And any small mistake in this area, either by the surgeon or by the anesthetist, can cost the patient his or her life, or they'll become invalid for their entire life, because the area is important. So it is presented like it's like a smooth walk for everyone, like the way you presented. It's very nice, but when you stand there, you are actually quite nervous when you're doing this, especially in the sitting position. So no questions as of now, as I can read from the chat box. So thank you so much, Dr. Prashant. We'll move on to the next speaker. Thanks a lot. I'd like to invite my next speaker. She's my colleague, Dr. Kiran Lata Kiro. She's a professor in my department, very dynamic and academic person. And her area of interest is pediatric neuroanesthesia, but today she's going to talk about an adult topic and a very common occurrence in society, that is intracranial aneurysms. We are seeing lots and lots of these cases because the patients are just walking in. So it's important to know, and it is another challenging area in neuroanesthesia, and actually another one which makes the surgeon as well as the anesthetist very nervous when you're standing in the OT. So over to you, Dr. Kiran. You can tell us about the anesthesia concerns in intracranial aneurysm.